So Dr. Trivedi is a consultant hepatologist at the Queen Elizabeth Hospital in Birmingham. That's one of the biggest in the UK. He can't answer any personal questions today about PSC because he's not got your health information or your records there, but he can answer questions all about PSC and PSC research. And actually, Dr. Trivedi is leading the UK-PSC research groups at the moment and several clinical trials. So, any research question, I expect Dr. Trivedi to be able to answer it fully. So thank you so much for joining us, and welcome, Dr. Trivedi.
Thank you for having me, and so apologies again for being late. I was coming from my PSC clinic, so I have a valid reason.
Good. Actually, the first question was for Mark, and that was about whether it was. So, Mark, are you still there?
I am. I'm just hiding.
What was your first call? The one for your transplant?
Yes, it was. I don't know how lucky that is in terms of other people. It's not a stat I know, but yeah, I got a call at 2 a.m, rushed down there, and it all went through. It was
brilliant.
Yeah, but I had been on the list to quantify that in terms of people who maybe have shorter waiting times and more non-matches, as I was on the waiting list for 3 years and 3 months. It was a long time.
Long old wait. And Dr. Trivedi, how often do you have a sense of how many false calls people, I don't want to say false calls, but how many calls people get for transplant before the one, or does it just vary?
I mean, it certainly varies, and I mean, I'd like to say that the first call you get will be the one, like in Mark's case, and certainly my own observation that usually is the case. But every month we'll have a handful of people who are called in, and then they have to be sent away, and that's not because something's wrong with them; it's because the donor was thought to be of a certain quality when its retrieval began, but on looking at it, assessing how it is in our surgeon's hands, we thought actually this is not the best liver for this particular person. So it's the risk of putting it in would outweigh the potential benefits. So that's usually why. But I'd like to think certainly most often than not. I mean, I can't really put any valid statistic, but as a best guess, I'd probably say at least about 60%. Maybe slightly higher. The first call you'll get will be the one for most people.
Thank you. That's reassuring, actually, because when you mostly hear from people when they're getting the second, when the first call's not been able to be the liver for them. Brilliant. Thanks, Mark.
Thank you.
No worries. I'll disappear in case you need me again.
Brilliant, thank you. So we've got loads of questions already, Dr. Trivedi, so we'll start. So can you tell me about HE, so that's hepatic encephalopathy, and the different levels of them?
Sure. So hepatic encephalopathy, or HE for short, it's a symptom that occurs in people when their liver cannot clear or filter out all the toxins in their body that it should do. And normally, in most people, the vast majority of your liver's blood supply comes from your bowel through a blood vessel called the portal vein. And between 2/3 to up to 90% of your liver's blood supply is from that portal vein that's derived from your gut, and some of it comes from your spleen in that same blood vessel. In people with PSC and other liver conditions, when the liver either becomes very stiff or scarred, or when it's not performing its function to cleanse the blood before going around the body, some of the toxins that you would normally filter out, they pass to the brain and act as what we call false neurotransmitters. So Martine, if I remember rightly, you're a neuroscientist by training many years ago, so you also know all about neurotransmitters. But these toxins then can act as false transmitters in the brain and make people feel more drowsy. Their sleep-wake cycle becomes reversed. They can become quite tremulous when doing certain actions. They appear to be confabulating and confused to their loved ones. And that is the signs and symptoms of encephalopathy. There are many different stages. Historically, what we would say is it was graded 1 to 4. There is now an earlier stage that we recognize, which is not given a number, but an adjective called minimal hepatic encephalopathy. And in stage 4, which is the most severe, that is like a comatose sort of state. Stage 3 is like a stuporous, drowsy state. Stage 2 is when people, you might have, some of you who are undergoing the transplant assessment process or have had a PSC for a while. If you're seeing a doctor and they get you to do the test where you put your hands out like this, and if the hands flap forward because they can't be kept in a steady position, that's sort of stage 2. And you're beginning to sort of lose, your sleep-wake cycle. So that's sort of stage 2 going into 3. And sort of stage 1 is general inability to do certain basic tests like dot-to-dot tests, for example, or drawing certain shapes that the doctors may ask you to do. Another one is some mental arithmetic, subtracting serial sevens. That sort of process, mental capacity becomes lost or slowed down in stage 1. And this sort of a term of minimal hepatic encephalopathy, it's very difficult to define. But if either the patient of out of mine, or you as an individual, or your loved ones feel that actually mentation, you're not quite right in terms of your joined up thinking, there are certain investigations that we can do to using specific bits of equipment, like certain brain tests, like called an EEG, or there is a very long name called critical flicker frequency, which is sort of the way that sort of your eyes sort of move and brain waves move. It's, those tests can be used to sort of see whether you've got any minimal encephalopathy. Now, it's important to recognize that this is different, although hard to distinguish, between the brain fog that can happen at any stage of PSC. Encephalopathy is a clinical diagnosis that requires a very experienced watch for somebody to detect in its earlier stages. I mean, the later stages can be diagnosed by medical students and allied healthcare professionals, but you need a very experienced person to pick up the subtleties at the beginning. And it's important to do that because the 2 or 3 implications are: number one, if you've got encephalopathy, particularly encephalopathy putting you into hospital, that is an indication for liver transplant assessment. Number 2, if you have encephalopathy that, however minimal, it means legally you are not allowed to drive. And number 3, sometimes we might give you a medicine to see whether it helps improve that symptom, medicine for encephalopathy, that you may benefit from. So it's important to sort of ask that question if you feel that you're not sure, is this brain fog, is this encephalopathy? And sometimes the doctor say, look, I don't think this is encephalopathy because you don't have cirrhosis, because there are no other features to indicate that your liver is under high pressure and not clearing toxins. Other certain things they may look for would be, is your spleen, your liver's neighbor, is that enlarged? That would increase the probability of you having encephalopathy. If, is there evidence that you have things called varices, swollen blood vessels in the gullet? That again increases your chances of encephalopathy, because the things that lead to encephalopathy, that pressure of the blood going to the liver because the liver's scarred and stiff, they can also cause these other complications. So if you've got one complication, you're more likely to have another.
Thank you. And it's for people, I guess, people that would have a hepatic encephalopathy, they would already have more advanced liver disease. It wouldn't come out of the blue with someone who has got no minimal cirrhosis. So
correct.
When you said about the brain fog, distinguishing it from the brain fog, I think a lot of people would have been thinking, oh, have I got it? But you'd know if you had advanced liver disease, wouldn't you, or cirrhosis, because your doctor would let you know. Good.
Yes.
Thank you. Okay, next question. From a cancer perspective in PSC, how would you know? Is it from scans, blood tests, or symptoms? This is another question that actually comes up a lot.
So you're asking if from any form of cancer related to PSC, is that what the question is, or is it a specific cancer?
I suspect it's PSC with biliary cancer and those ones that we hear about most often, even though they're rare.
So gallbladder, so gallbladder cancers and liver cancers, we would identify through scans. So it's very important. Excuse me, getting hiccups. It's very important for anybody with PSC, whether it's small duct PSC, classical large duct PSC, to have a scan of their liver once a year with an ultrasound, a basic ultrasound scan, and that's predominantly to look at gallbladder polyps. And of course, if you've had your gallbladder removed, then that risk is no more. But people with a gallbladder intact, they would require an ultrasound scan as a bare basic minimum every year. The ultrasound also helps look at the liver proper, because there is a slightly increased risk of developing liver tumours, liver cancers, cancers within the liver itself. We would like to pick up most of these at a pre-cancerous stage, again on an ultrasound scan, or at an early cancerous stage. So that's another reason why having a scan done every year is important. Now, liver cancers are the least common cancer out of the worrisome ones that we see in people with PSC, and they're less common in PSC than actually many other liver diseases. But they only tend to occur, as far as we understand so far, in people with PSC when you have cirrhosis, a bit like encephalopathy. So when somebody has cirrhosis, whether or not they have a gallbladder, we would still be doing an ultrasound scan every 6 to 12 months to look at the liver itself. And if they obviously have a gallbladder, we will look at that at the same time. So gallbladder cancer is a scan every 12 months. If you've got cirrhosis, that scan goes to every 6 months, because we want to look at the liver as well. Colonoscopies are slightly different. So colonoscopies are, of course, a telescope test to look in the large bowel of people who've got PSC and colitis, and that is required every 1 to 2 years to see if there are any precancerous changes, any undertreated inflammation that can herald cancer in later life. That's how we would diagnose them. For those 3 entities, gallbladder cancer, liver cancer and bowel cancer, we are not reliant on blood tests. Now, yes, there are some blood tests that if they're up, we might increase our concern index of suspicion, but broadly speaking, these are not, the blood tests are not designed to look for these 3 things. There is an increased risk of cancer in the pancreas and, of course, in the bile ducts, what we call cholangiocarcinoma. Now, pancreas cancer, with modern imaging techniques, is quite easy to diagnose. We can see some suggestive changes on an MRI scan. We can see some suggestive changes on an ultrasound, but there is no surveillance practice specifically for pancreatic cancer in PSC. We stick with the ultrasound for now, and an MRI scan every 1 to 3 years, I would say, sort of is the average from most UK centres. And if we see that there are changes in the pancreas or in the surrounding structures, like the bile ducts look suddenly more swollen than they ought to be, that would increase our index of suspicion. But again, this is not something that we would anticipate on a blood test. Bile duct cancer, or cholangiocarcinoma, is the one that we worry about the most. So this is a cancer that's very difficult to treat, and it can occur in about 10 to 15% of people that we're living with PSC. It's difficult to identify, not because our tools are useless, but because most people who develop bile duct cancer, they do so within a year or 2 of their PSC being diagnosed, rather than later on down the line. So actually, after somebody's been followed up with PSC for 1 to 2 years, the chances of getting cancer are about 0.5% to 1% every year. So it's actually very low. But that first 1 to 2 years after your PSC is diagnosed, particularly if you've got jaundice, that's when we start to really worry about a bile duct cancer. Now, the imaging tests that we use are more than one. We complement our ultrasound and MRI scans with a CT scan, and sometimes with a telescope test directly into the bile ducts to take samples. The blood tests that we measure in routine day-to-day practice, like your liver biochemistry, for example, they won't tell us whether you're at risk of developing bile duct cancer or not. But if there's a sudden jump, a sudden change in your blood test, so for example, one day you're absolutely fine, the next day you've been diagnosed with PSC, and within a few weeks or months you've become jaundiced or yellow, that's when we start to worry about bile duct cancer, and we are more aggressive, should I say, in terms of the investigations that we would offer you to exclude bile duct cancer. There are certain cancer markers in blood that people use. The problems with these are they're not really cancer markers, they're markers of bile duct problems. So they may be raised in many people with PSC who don't have cancer. So I don't use any of these in my practice to screen for cancer at the moment.
So it's a case of looking at all the tests that you have available and looking at how things are changing, as opposed to one test on its own results.
Correct, yeah. But I think, I'm sure PSC Support have got something on the website about what we would expect as a minimum standard for surveillance. But if not, we can certainly put something together as a group. This is the minimum that we would expect everybody with PSC to have.
Yeah, we've got details about the UK guidelines and what's to expect according to them. We've not updated generally over the website about the European ones yet. So we're still very UK based.
Okay.
Thank you very much for that. As we've got quite a few questions, I'm just going to quickly scan them for the research ones first. Here's one about the Integris research, and they would just like a quick summary of what was announced a couple of weeks ago.
Sure. So Integris was a clinical trial in people with PSC. So clinical trials are research exercises wherein a new medicine is being tested, and it is a test, to see if it makes a difference in a particular disease parameter. They come in different phases, sort of simplistically divided into phase 1, phase 2, phase 3. And phase 1 is very much where somebody or a small group of people get given a new drug. It's tested to see whether it's safe, and whether there is any concerning safety signal which would stop its development any further. And there may be some dose escalation where they're trying to push the dose higher and higher. And often phase 1 studies are built upon a background of prior work in the laboratory on cells, on animals, and so on and so forth. The phase 2 studies, which is what the Integris study was, can still be a safety study, but they look at other markers to see whether the drug is effective. So they may look at things like scarring in the liver, colitis activity, liver blood tests, biomarkers of the condition getting worse. And in the phase 2 study, they can either be with a control group, so where half the group or a certain proportion of patients do not get the study medication, versus a group of individuals who do get the study medication, the experimental therapy, and the differences are compared. And then a phase 3 study is where we want to confirm that data in a larger group of people. We don't just look at a few small things to see whether it's effective, but a huge range of things, often over a much longer time period. The Integris study is a phase 2 study where if you divide people into 5 groups, 4 of those groups got the medication. 1 of the groups got a dummy pill, a placebo, and nobody knew until the results were analysed who got what. The Integris results have been presented in preliminary format in their press release, where they looked at the dummy pill group, the control group, and 3 of the doses. The 4th dosage group that they're going to use has not been reported yet. But they looked at those 3 dose groups plus the placebo group, and they compared the results. Now, what they found was that there were no significant safety signals that are going to stop this drug from developing further. It's a tablet compound that is designed to reduce the amount of scar tissue that a PSC liver makes. The exciting part of the results came from analysis of circulating markers of scar tissue formation in the liver, fibrosis, the things that lead to people developing cirrhosis and eventually needing a liver transplant. What they found was that people in the placebo group, or the dummy pill group, they had increased markers of fibrosis over time because they're not on anything active, so their disease continued to progress. But people in the highest of the 3 presented dose groups had very little, if any, progression in their liver disease, according to this blood-based biomarker, over a 12-week period. Now, that's critically important. It's a 12-week study, a very short-term study, and it's a blood-based biomarker. So it's provided some proof of concept that this drug is slowing down the rate of fibrosis, rate of scar tissue formation, at least in the short term. The next stage of this would obviously wanting to read out for the higher dose group, would also be wanting to look to see how it improves particular symptoms of PSC. And I can't talk more about that at the moment until those results are shown and released by the company. But there are some exciting signals in there, which hopefully we'll learn about soon. And we also now need to go to the regulators of the world, in the United States and North America, elsewhere in North America, Europe, and in the UK. And they all operate on a slightly different wavelength, and say to them, we now wish to conduct a study long-term of this compound, looking at something beyond just a blood-based biomarker at 12 weeks, and see whether these results can be validated long-term, or is it something that even in the short term, it has an effect, but long-term there is no benefit. So that's the next stage. But it's exciting because it's one of the, well, it's probably the only drug that I can think of that has shown a positive result at this early stage in a blood-based marker of fibrosis that we use in routine clinical practice. There was another trial many years ago, like 4 years ago, which showed in a different marker that is more of a research tool, but not a marker that we use in routine clinical practice. And that program didn't get developed any further. So the results are exciting, and I'm hopeful that when we do this next time, we'll have more results from the Integris program.
Yeah, brilliant. No, it is good news. And I hope that after those results come through, it does move on to the next phase. Right. Another question about research here is, a couple of months ago, Dr. Trivedi talked to us about fetal transplant therapy. How is that study going? That's a good question.
It's a very good question. Yeah, so we've got approval to do the study from the UK authorities. So anytime you have a trial, you have to write a wealth of documents, usually 20 or 30 documents for submission. That normally takes about 9 months. We submitted those in March, and we got the feedback for those in September, saying, or end of September or beginning of October, saying that we're allowed to start. So that's good. We are now in the process of asking, and following that, each hospital has to then approve it once we've got UK approval. So that's the process we're at now. So we're hoping that Birmingham would be the first site to open. So it's currently sat with our research and development department, and they are agreeing, protocols and templates. But without the UK approval, they wouldn't have been able to do that. So now that's currently where we're at. So we haven't started it yet because, but we've got the rate limiting step under the way, which was UK approval for from an ethics perspective.
Thank you. And that, I mean, there's a lot of people asking about this study. Are you going to try to time it around people's annual colonoscopies? So if someone's 6 months away, but they're keen to get on that trial, they could approach their doctor and ask, but it might be that it's sensible to wait till your usual colonoscopy.
Yeah, so we advise colonoscopies in people with PSC associated colitis every 12 months. But that's the average. We normally say every 1 to 2 years. So if you're really keen to do the study and you're at 9 months, for your colonoscopy, that's fine. We can still approach you, and you can still have it slightly earlier, and then your next colonoscopy will be 12 months afterwards. And in turn, if you're right now at 12 or 13 months, but you want to wait for it to open, the guideline is every 1 to 2 years. So you still got another 11 months or so to have your colonoscopy. So you can wait until you have one as part of the trial. That is absolutely acceptable.
Brilliant. Thank you. Any more research questions? Here's one. This is a really interesting one. Are there any global studies of PSC to understand why some populations are more susceptible to PSC than others? In the UK, I think he's put some incidence figures here. UK 7 in 100,000. Okay, or is it prevalence?
So why are some people more susceptible at getting PSC? Is that what they mean?
I think so. And then they've compared a UK and Japan incidence, I think.
Yeah, that's a very good question. So we don't know why people develop PSC. We recognise that there is a strong association with inflammatory bowel disease. So there are efforts here in Birmingham, in the UK, and in other parts of the world, looking at the genetics, looking at the gut microbiome, and also whether there are other exposures that somebody may have had in their life, what we call a phenome-wide association study, to identify why people develop PSC. What we certainly recognise is that there are certain types of inflammatory bowel disease that are more predisposed. So if somebody has colitis the whole way around, if somebody has precancerous changes on one side of the bowel, then they are more likely to be diagnosed with PSC than others. And there was a study from Oxford a few years ago led by Dr. Emma Culver and Roger Chapman, and it showed that in people who've got colitis, who have had cancer or what we call dysplasia, precancerous change in their colon, then about 20%, so 1 in 5 people, would have features of PSC, even if their liver tests are normal. So that's sort of the closest that we've come in terms of it's the distribution of colitis. I wouldn't say it's predictive, but it's most associated with concomitant PSC. From a genetic standpoint, it's not a particular gene that we have identified that leads to PSC. It's a collection of different genes that are more commonly found in people with PSC and inflammatory bowel disease, that if they've got those particular genes, they are more likely to get PSC. Now, more likely doesn't mean that they definitely will. So that's why we believe that your genetics accounts for less than 20% of the total reason why somebody gets it. The rest of it's all due to environment and gut microbiome, really.
And I think Birmingham has done this research where you're finding that there are more people being diagnosed with PSC, and have done a prediction to say in a few more years, actually, there's going to be more than ever. Do you think that's because of these different environmental factors, or are we getting better at diagnosing PSC?
I think it's a bit of both. I mean, our study was done over a very short period of time, showing how PSC is going up. Now, if you've got people like myself and others who talk about PSC a lot and make people more aware, there will be more diagnoses, and the technology of MRI is also better. So a lot of people who are diagnosed with early PSC now would not have been diagnosed many years ago with older MRI scanners. So it's a bit of both. I think awareness rising has also led to an increased diagnosis. But I also believe that it's certainly because of our genes haven't changed dramatically, but the environmental exposures have changed dramatically. And that's certainly why we see more PSC in the more northern parts of the world, less in the Mediterranean belt, and virtually hardly ever in Far East Asia and Southeast Asia. So I certainly think that urbanization, more ultra-processed foods and things are a global driver of autoimmunity. And we see rising levels of autoimmunity, not just PSC, but loads of other autoimmune diseases. And it's estimated that about 4% of the world now has an autoimmune disease, which 20, 30 years ago, nobody would have imagined.
Mm-hmm. Hopefully we'll be able to get a proper treatment for our one soon. So just going back to the Integris trial, somebody's saying that they took part in this trial, and would they be able to find out now whether they're on the placebo or the active drug?
I think they would be able to find out once the highest dose group is read out, because some people are still in that group, and we don't know what the results of that are. So you will be able to find out. I don't think you can find out yet.
Yeah, it normally is kept very secret, isn't it, until all of the results have been analysed before people can find out, unless it's an emergency.
Correct.
Yeah, good, thank you. I'll just tick that we've answered that. I saw a question about mice models. Here we are. I recall early stage research conducted on mice that had showcase examples where we were able to put PSC into remission. Can you elaborate a bit more on that, please?
Yeah, so there are a lot of animal models with lots of different drugs where we've been able to cure bile duct changes that are pretty much the same as PSC in humans. There is a huge bottleneck between mouse studies and positive human results. So it's very hard to, it's very easy in a mouse model to cure something. You can certainly cure something very easily in a mouse model, and then when it comes to the human studies, because we're not caged animals in a controlled environment where people are feeding us things that are very specific, to sort of prove the same thing. So, for example, norasodioxycholic acid, which is another phase 3 trial, which will read out its final results next year, I believe. That study has shown in multiple animal models to cure, PSC-like changes, bile duct changes, and we hope that it does the same thing in the human studies population, but we just don't yet know. The Integris compound, bexotegrast, as it's called, has shown the same thing. And even if you delete the gene that bexotegrast targets, you get the same effect. So even if you can prevent bile duct changes developing. But sadly, there are other compounds. So there was a drug, there's a trial called Primis, which was recently presented, and that was an agent called silafexor, which was used. That particular agent, when it's given to animal models that look like PSC, it improves things, and certainly in man, even it improved liver blood tests. But in the human studies were negative. It didn't show any impact on fibrosis. So there are lots of different animal studies with lots of different compounds that have shown a positive result of removing PSC-like changes. I mean, animals don't tend to get PSC; they get a slightly different variant, depending on the animal model you use. But so we use those as a primer or as a proof of concept that there may be some benefit in studying it in humans. But there are dozens and dozens of agents like that which have been shown to work in animals, which have not made it through clinical trials because of negative results. So we certainly hope that the bexotegrast and the norurso are two compounds that do show changes in the human condition, not just in animals.
Yeah, thank you. Fingers crossed. This question is, what are your limitations for increasing research output from current trials? Is it not enough researchers, data scientists, grad students, etc.?
So what are the barriers? Was that the question?
Limitations. So I think this would apply to academic research as well.
So I think first and foremost, it's staffing. I mean, we would have been able to open many more PSC trials if the NHS was funded properly, and we would not have had the mass exodus of nursing staff following the mandatory payment of tuition fees, COVID pandemic that led to everybody being burnt out and not being allowed to take leave, for example. That sort of thing has led to a huge exodus of nurses. And even in Birmingham, I would like to do many more trials in PSC, but our research and development department, our liver research department, has only a certain bandwidth. Now, if we were at the same capacity as we were in 2019, 2018, we would be doing all the trials that I want to do, not just for PSC, but other conditions as well. And it's not just PSC that's been affected. Trials in inflammatory bowel disease, trials in cancer, others have also been affected by the shortages of staffing. And it is very much that our concerns are being fed, are falling on deaf ears. We're saying, right, you just have to deal with what you can deal with. And even the fecal transplant trial, even if it's my trial in Birmingham. When I say my trial, what I mean is a trial that I've obtained funding for, that I'm driving forward. It is very much, that's great, Dr. Trivedi, but you have to wait for your turn in the queue for us to review it and sign it off, even if it's very strategically important. So I think the biggest barrier is lack of staffing from nurses. The second thing I'd certainly say from a funding perspective, when there are lots of, and Martin, with your research on PSC support, I'm sure you can add to this, that the amount of public sector funding with an interest in rare disease and PSC is very small, so what happens is that when PSC support or other organizations like LifeArc, for example, have an interest in rare disease, have an interest in PSC specifically, then they would very much say, okay, that's fine. We're going to, we've got, they'll get dozens or hundreds of applications, and they can only pick one or two because they've only got a certain remit. So I'm sure if everybody with an interest in PSC was to apply to PSC support, you want to fund them all, but but your pockets aren't going to be as deep as someone like the NIH or the Medical Research Council and so on and so forth. You can probably fund one or two projects a year, rather than say 12 to 15 a year, which is what the application rate would be for a PSC specific study. So I certainly think funding and the interest in funding high risk projects, not risk in terms of the patient, but risk in terms of this may turn into something amazing, may turn into something that's nothing, isn't there for PSC and rare disease like it is for more common conditions. So I think funding is the second bit. We're
competing with the common liver diseases, aren't we?
Yes.
You know, the big funding bodies will say, oh, but you'll be able to help thousands of patients with PSC, but hundreds of patients with fatty liver disease, for example. So the competition's really, really stiff. And I think the thing we've found, isn't it, is about when PSC researchers put applications in for large amounts of funding, those bodies say, well, like you said, it is high risk because you've got no data to say that this is going to work, and you need to provide some data. And actually that's where PSC support comes in, because we want to fund those small studies that will allow you to get that bigger funding, that allow you to generate more data. But I mean, you all work incredibly hard, all of you do. Certainly you and I have emailed on Sunday nights doing research applications and things. So it's not for lack of hard work, it's lack of resources, I think, is the number of trials.
Yeah, no, I mean, I'm very grateful. I don't think any of us would be able to do any of the work we do without PSC support. I have to admit, I mean, it's just, we're very lucky in the UK to have you and have the interest in research. The other countries aren't so lucky. But I do know elsewhere in Europe, like Germany, for example, the fund, and in Norway and even in France, the bar for getting studies funded is a lot lower than it is in the UK. And I'm not to say that their research is any less important. It's certainly not. It's very high quality indeed. But if you want to do a clinical trial to see whether you make somebody feel better, and you also improve their scan appearances or their blood tests, that would get funded in France. Here, you would have to prove that it's something a lot more tangible, something that is like, does a liver biopsies get better over several years? Now, whilst people may be open to a liver biopsy once or twice, having it done 4 or 5 times year on year is not appropriate in any condition. And they said, well, why don't you run a trial to see whether it reduces the chances of people getting a transplant or dying from their PSC? And think, I would love to do that sort of study. I would love to show that. But the problem in a trial is that you would need to wait 15 to 20 years from diagnosis for that to happen. And that's economically not viable. And it's committing a patient, their family, their own doctors to an investigate, to almost like an experiment for that long, is in some places unethical. So when you've got something like PSC, which affects people over years rather than days and weeks, it becomes a lot more difficult to justify to a funder. This is why you should support this study. I have no idea whether my drug's going to affect long-term outcome, but I want to see whether it improves blood tests and scans and makes them feel better. The UK sort of groups are less receptive to that. So that's the challenge.
Yeah, it is a challenge. Thank you. Next question. Are any further trials for PSC without IBD coming along, please, including fetal?
Yes. Yeah, sure. So what we hope will happen is, so the reason that we've gone for people with PSC and inflammatory bowel disease for the fecal transplant is just because there is data in people with inflammatory bowel disease showing that fecal transplantation works. So that's why this was a logical next step. And if it's not going to work in people with inflammatory bowel disease, sadly, I don't think that our strategy will work for people without inflammatory bowel disease. So we wanted to go for the lowest hanging fruit because of all the things that I mentioned about the difficulties in getting studies funded and where the most evidence is. But yes, there will be trials for people without inflammatory bowel disease. So most of them, in fact, do not require you to have inflammatory bowel disease. So the Integris trial, the NORA trial, both of which have finished recruitment now, did not require people to have inflammatory bowel disease. There is a study that we are currently doing by a company called Escient Pharma. The study's name is Pacific. It's to look at itch attenuation. That does not require anybody to have have inflammatory bowel disease. There is a study called Vistus, which is another compound looking at itch or treating itch. Does not require anybody to have colitis. There's a trial called Elmwood, which is by a company called Ipsen, which we hope to open very soon here, which is a once daily tablet, and that's not going to require people to have inflammatory bowel disease. And there are a whole host of others that will be coming up next year. I can't mention at the moment, but most of them will not require somebody to have inflammatory bowel disease.
Thank you. And the ones that we can mention are on our website, and we can put the links in the video when we publish it.
Yes.
And the other thing to mention is actually the trials, sometimes they're quite hard to get onto, aren't they? Even though, you know, there are trials coming along where you don't have to have IBD. But it's something, I think in phase 4 or later, that's when it starts to expand the people who can have the drug, isn't it? They wouldn't limit it so narrowly. Am I right in thinking that? So eventually everybody should be able to get that drug, even though it was initially only tested on a very small group.
Yeah, so the idea is that when you're in a trial, then you should have benefit to yourself from it. And part of that benefit would be that, yes, you get monitored more regularly, but above all, if the drug is shown to have some benefit, then you would be able to receive that compound long-term before, as part of an open label study, i.e. you're definitely on the compound, you're not on the placebo, and you will just see what happens. Now that's very much not exclusively limited to, but very much limited to the phase 3 trials. But some of the phase 2 trials do allow you to have an open label phase. They absolutely do, and we then follow you up as if you're still in the trial, but we know that you're on the active compound. So most of the trials won't commit to an open label phase at the start until they know that there is some benefit to their drug. Even if it's over a short-term period, like the Integris trial, for instance, they would not commit right at the beginning until they know that their drug's going to have some benefit.
Good, thank you. Quick question here: can people from out of the UK take part in the fetal transplant study?
You have to be registered. You have to have an UK NHS number to take part in our fecal transplant trial here. So you have to, and you have to, because of the intensity of visits at the start, you would have to have a UK address, which is perhaps slightly easier to get. So unfortunately, you can't take part of it whilst you're abroad, but if you are in the UK, then you can.
Good, thank you. Right, we've got so many questions here. Can you see the questions, Dr. Trivedi?
No.
Oh, that's a shame. Right, there's quite a lot of questions here, and I'm trying to prioritize the research ones. And I saw a good one a moment ago. Can we have an update on the vancomycin trials and confirm whether there are any negative proof of resistance causing problems?
Yeah, absolutely. So there are a number of vancomycin trials taking part throughout the world. The one that we did in the UK was to see whether it would help colitis activity and liver blood tests over a short 4-week period, stopping it at 4 weeks and seeing what happens as on stopping. And secondly, find out what the gut microbial players and pathways that are associated with responding to it are. So to that effect, we completed the trial, I think end of last year or beginning of this year. And when we did that study, everybody's colitis got better. So it was designed, predominantly, as I mentioned, for getting the colitis better, and everyone's colitis got better. And when we stopped it, then we saw markers of colitis rise, and people did have paired colonoscopies and then sigmoidoscopies to show that the colitis had got better in between. And we found out that there are certain pathways associated with how the bowel handles bile that were associated with responding to vancomycin. In terms of resistant bacteria, so yes, we did identify emergence of some resistant bacteria, which has caused a bit of concern. We are currently interrogating that with our microbiology researchers to see whether it's something that is clinically meaningful, i.e. will cause that person harm day-to-day living, or is it just that the genes of these bacteria changed slightly, but it doesn't really make that much of a difference, So nobody's going to sort of, maybe some people do care, but nobody's going to sort of care too much if the crust on your pizza is slightly burnt, as long as the rest of it tastes okay. But some people might do. You never know. So what we need to know is whether it's something that's going to meaningfully change the sort of way health, or whether it's just an incidental finding that is not going to mean much. So that's the sort of phase we're at the moment. Elsewhere in the world, there have been vancomycin studies from many years ago which showed liver blood tests improving. We don't know if that's because of the effect on the gut primarily, and we know that there is lots of data now showing that if you have bowel surgery to remove your large bowel at certain points in your life, it will reduce the risk of needing a transplant, reduce the risk of getting recurrent disease after transplant. All of that data strongly supports the fact that PSC is driven by things in the gut. So if we can achieve things with something as simple as vancomycin, that will be the holy grail, really. So the groups in Italy are doing a randomized control study, placebo versus oral vancomycin treatment. I can't remember what their primary readout is, but it's not colitis activity. I think it's just liver blood tests. And the studies in North America, I think, are looking at liver blood tests as well as the main readout. Here, we're looking for colitis activity first, because we know that it works for that. And we're looking at the liver blood tests second, because they're a lot harder to follow long term. Not just blood tests, but what happens to the liver. It's very difficult. It's a lot more challenging to prove a beneficial effect on liver health long term. But colitis, because we can just look with a telescope, it's a lot more easier to prove that the drug works. So the next step for us is teasing out those safety concerns, whether they're something or whether they're nothing. And provided that they're nothing or something, or sort of and not too meaningful, we would be planning a longer term randomized study between a placebo group versus an active treatment group.
Thank you. And I'm speaking as a patient. I'm really glad to see the research being done on vancomycin, since we've been hearing about it for so long.
Yeah.
Get very extreme views, and for us, we just want to know whether it's going to help us or not, or harm.
Of course.
us. I'm glad you're doing that research.
Yeah.
Okay, next question.
It's just popping up just to say we're getting quite close to 2 o'clock. Just throw a little reminder in there, and then I would disappear again.
Thank you.
Would you want me to? I mean, I'm very happy to do another, because today's one was a bit short because it's in between clinic visits. But I'm very happy to do another 1 or 2 of these if it's helpful.
That would be brilliant, Palak, because we've got quite a lot more questions here, and there's a lot coming in the background as well as on the chat. So that was really, really good. So shall we arrange some dates between us afterwards with Paul?
Yeah, and we can do them relatively short in a short space of time. So I think in a couple of weeks or something, just so people don't forget what they've asked and things.
Yeah, thank you. And we'll make a note of all these questions. Shall we have one last one before you?
Yes, of course.
Okay. Do the studies confirm what the role is of cholesterol in PSC? Can high cholesterol cause bile duct inflammation? And if so, does HDL have a protective effect on the biliary tract?
That's a very good question. So I don't believe there have been studies looking at the direct effect of cholesterol, but what we do see in the bile ducts of somebody with PSC, it looks very similar to blood vessels affected by atherosclerosis. So they're sort of the irregularities that develop in blood vessels when they're affected by cholesterol plaques and hardening by age. Look similar to what the bile ducts do in somebody with PSC, but I don't believe there's been any direct. I'm pretty sure there isn't any evidence to show that cholesterol itself harms the bile ducts. It can, of course, cause harm to the liver proper, so you can get fatty liver with high cholesterol. But I don't believe there's any studies showing how cholesterol affects the bile ducts. So I'm not saying that there is no effect. I just don't think there are any studies out there to look at it in any significant degree. If the person who's asking it is aware of that, we're very happy to read it, though.
And do you often see high cholesterol in people with PSC, or no more than the general population?
No, we certainly do see it in PBC. In any condition that affects bile, we can see high cholesterol. It's not often a dangerous cholesterol, though. It's something called lipoprotein X, which you don't get measured by routine clinical testing. But it's supposed to be a little bit protective, if anything. So we know in a related condition called primary biliary cholangitis, PBC, that the high levels of lipoprotein X actually were protective. So we don't automatically treat high cholesterol unless there's another risk factor like smoking, obesity, high blood pressure, diabetes. But it's very common. It's anything that can affect bile can affect your cholesterol.
Thank you. Right, 58 minutes. We've got 2 minutes. I think we can do one more very quick one. Do you agree? Thank you.
Yeah.
Are there any studies going on related to women in perimenopause in PSC? Just wondering if hormonal changes due to age are related to disease progression.
So there aren't any ongoing studies that I'm aware of, but there have been studies showing that women actually, on the whole, do better. And the older you are when you're diagnosed with PSC, you do better. So there's a 25% lower risk of needing things like liver transplants and so on and so forth in women compared to men. And what we see is that people, the older you are when you're diagnosed, the less likely PSC is going to be, going to cause a problem needing liver transplant or to take you from this world. It's much less likely that PSC will be that. So the people that I worry about the most are people of younger age, not sort of who are like in their teens or early 20s, 30s, 40s. When I see somebody who's diagnosed with PSC sort of in older age, for example, 60s, 70s, I'm a lot less concerned because the condition tends to progress much less in those individuals. So certainly I would say that I'm not making any presumptions here, but if this particular individual is asking a question, if they're in their 50s when they're diagnosed, when they are after the menopausal change, actually their outcome might be better. But again, I haven't seen the history. This is a broad generalization, but as a group, older people and women tend to do much better.
Thank you. Well, it's always nice to hear something positive.
Yeah.
So we're at time now, Dr. Trivedi. So thank you so much for coming on and answering everything so clearly as always, and giving up your time for free for us. We really appreciate it. For everyone else, thank you for joining us. Thank you for excellent questions again. And I'm sorry we didn't get to answer them, but we'll go offline and see when we can arrange the next Ask the Expert to get some more of these answered. In the meantime, it's Global PSC Awareness Day on Sunday, the 29th of October. So just keep an eye out on our social media for posts. And if you see them, do share them as widely as possible. And they'll be on PSC Support and the other international PSC groups. And so with that, it's time for us to go. So thank you again, Dr. Trivedi. We really appreciate you coming on. And we'll see you next time.
Great. Thank you, Martin. Thank you, Mark. Thank you all.
Bye-bye.
Bye.